All right, we are part 2 of exam 2 review. Let's take a look here. Okay, alterations of cardiovascular function in children. So generally, we're looking at some sort of congenital issue that they are born with. So if you can picture that septum between the atria, that should be closed, right? Because when blood flows, it should go through the right side of the heart to the lungs, left side of the heart to the body. If that doesn't sound familiar, you know what you should do. So atrial septal defect is some sort of opening between the atria. So it can be other than this, but one of the main ones that I've learned was patent foramen ovale. There's a little hole that allows a bypass in a fetus, because a fetus doesn't necessarily have to send any blood to their lungs. They breathe through their mother. So they bypass their lungs in multiple shunts. One of them is the foramen ovale. Some people it stays open. One of my students, when I taught this years ago, told me her grandmother found she had one when she was 80. So depending on how big they are, you can live with it. If it's really big, obviously you can't, because you get a mixing of oxygenated and deoxygenated blood. Ventral septal defect is the most common defect in newborns when we're talking about these septal defects. And there's some sort of connection between the right and the left ventricle. And I show you a picture below. Patent ductus arteriosus. So, remember I spoke to you about the shunts. There's a shunt from this pulmonary artery to the aorta. And that's called the ductus arteriosus. When we're born, we take a breath, it shuts down, it turns into a ligament, okay? In some cases, it can stay open. Patent means open, okay? So now blood can combine from the right side of the heart to the left side of the heart, right? Because it'll shoot it from the right side up into the aorta, which is not good. So you got to do a little legwork. You got to determine whether it's a left to right shunt or a right to left shunt, okay? So check that out. Tetralogy of Fallot. So with this condition, there's a multitude of things that can go wrong. You have ventricular septal defect. So you have an intermingling of right and left-sided blood in the ventricles. You have what's called pulmonary stenosis, which is a narrowing of the pulmonary trunk. Okay. I believe there's coarctation of the aorta as well. Hold on a second. Got that head. Hold on. Let's go here. I had grabbed this picture thinking that all of the issues were here, but they're not. The last thing is called coarctation of the aorta. You don't need to know that. What you need to know is the aorta actually is open to both ventricles. Okay? So there's multiple issues for these babies, and I assume that they won't absolutely need surgery to fix them. God no. All right, so babies with Down syndrome have a very strong disposition to ventricular septal defect. Know how that affects the oxygenation of their blood. Okay, moving on to pulmonary system. Respiratory system, very important, obviously, to help us breathe. Helps us with discarding CO2. CO2 is acidic, it balances our pH. So in order to breathe, the diaphragm lowers, decreasing the pressure in the lungs, allowing air to flow in. It's all about a balance of the air pressure in your lungs versus the external environment. So if you decrease the pressure in your lungs, more air flows in. If you allow the diaphragm to relax and raise, air is forced out. And that's basically how we breathe. Unless you're talking about very forced breathing. Our patients that have maybe emphysema or asthmatics, or if you go work out, you can use what are called accessory muscles Those are the muscles in the neck and the intercostal muscles, which allow us to increase the capacity so we can bring more air in and we can push more air out. Now, the lungs essentially have a double layer membrane around them that helps to protect the lungs, keep them in place. There's also a fluid, like a seriously watery fluid between, in a normal patient, in a healthy patient, I should say, between these two membranes that helps to create tension, which pulls the lungs in. Okay, but our lungs want to collapse. Our lungs are a bunch of single-celled, layered air membranes. They just do, right? This double layer around them helps to pull the lungs out. And also, we always have a little extra air left, even after our deepest exhalation, to keep those alveoli, which are the tiny air pockets, from collapsing. So just some mechanisms that are important for you to know. So basic organs, you got this, right? Nose, pharynx. Pharynx is a common tube that goes to the esophagus and the trachea. Larynx is our voice box. Bronchi are the primary branches off the trachea, which then turn into bronchioles, okay? And then we get down to, so really you should have bronchioles in there, okay? So bronchi are the large tubes, bronchioles are the smaller tubes. You know that from listening to the lungs. And at the bottom part of each of the bronchioles, we have the alveoli. Diaphragm sits underneath, and you can see this represents that double layer I spoke about, except it's right up against the lungs. They have it spread, maybe it's just coming out a little bit. 2 lobes left, 3 lobes right, just a reminder. Okay. Upper respiratory tract, and once again, you don't need to know all these, I'm just trying to give you some background. Here's the opening from the ears. Okay, that's the opening of the auditory tube that helps to regulate the pressure of the middle ear. Here's the epiglottis, which will close off the larynx in case we inspire food. We want to block that off. I'm really not going to get crazy with this. I don't want you to think you need to know a lot of this. I just want to give you a reference point. So here's the trachea, and here's the esophagus. And the trachea is kept open because remember I told you breathing is passive. And it deals with a change of pressure. So we've got that open airway because we can't force the air in. Okay, I got a little crazy with the pictures. You can look at this if you like. There's really, I think it was the parietal membranes, but I already explained them on the previous slide. I got a little crazy with the pictures, so take a peek if you like. Okay, so spirometry is measure of the function of the lungs. I am sure that you've seen spirometry in action. It's all computerized now. We used to have this big old machine where you'd actually see the breath go in and out by a counterweighted system. It was actually very cool. But anyway, I want to go over the very, very basics of this. I know this looks like a lot, but I'm going to make this really, really easy. And we're only going to look at this column here, okay? Tidal volume, just your breathing. It's what you're doing right now, okay? A little bit in, a little bit out all the time. Now, if you decide to go work out, you need to have more volume. This is where we get inspiratory and expiratory reserve volumes. So this allows us to bring in more air and expire more air, because if you bring in more oxygen, you'll have more CO2. So inspiratory and expiratory reserves. Now, residual volume is what's left over, also known as functional residual volume. It's what's left over in the alveoli to keep them open so they don't collapse. Yeah, okay. Asthma. So the little critters that are often increased with asthma are eosinophils. For some reason, we tend to have an increase in those in many asthmatics, which causes more inflammation and hyperresponsiveness of the bronchi and the bronchioles, so they constrict. It's almost like you're breathing through a tube, like a straw, okay, just to give you a visual. Because they constrict, you can't bring more air in, okay? Who does asthma affect? It can affect anyone, okay? Higher in adults, 8% than in children. Children are about 6 to 7%. You see higher in females, 10% compared to males. Okay, so just to give you some general ideas. So adults about 8 to 9%. Children, it looks closer to 6 to 7%. COPD is a kind of collection or grouping, constrictive, chronic obstructive pulmonary disease that include chronic bronchitis and emphysema, not acute bronchitis. Acute is like you get sick, that infection spreads into your bronchi, you get that really crazy voice. My voice gets awful. It's much better than it used to be when I was younger, but and then chronic is more people who have damaged their airways and have difficulty breathing, and more of a chronic inflammation in that area. So with bronchitis, especially with chronic, you get more of like a neutrophil, macrophage, and lymphocyte infiltration into that region. So definitely know those cells. Alpha-1 antitrypsin. Something went wrong with the formatting. So please make note, this should be like out on its own. Okay. So alpha-1 antitrypsin is a protein that normally protects the lungs. Some patients can be deficient in it, and it can lead to chronic bronchitis, emphysema, asthma. It's really kind of a sad thing. And this can pop up in people who have never been smokers, and they can end up with issues. So definitely know about that protein. Okay. Oh, I know what I did. I moved this down because I could not get it formatted and just put pulmonary continued. So apologize. It's a little clunky, but pneumonias. Okay. No atypical versus typical, and know their causes. So definitely know the causes for typical pneumonia. And then atypical, also known as walking pneumonia, can be caused by mycoplasma, pneumonia, chlamydia, Legionnaire's disease can lead to it. I think that's what they mean by that. I mean, I know that is the bacteria, but I don't know how to say that. And then with typical pneumonia, you have more like influenza, staph, and strep causing that. But either way, you could have hospital-acquired, ventilator-associated MRSA. Oh boy, that would be scary. So either way, you're going to get that inflammation into the lungs and fluid into the lungs, and those signs and symptoms of coughing, feverish, sweating, those typical. But know the different contagions with typical and atypical. Okay. Acute respiratory distress syndrome is when there is damage or severe illness, which can lead to massive inflammation and fluid around the alveoli. And, from what I understand, this is pretty scary when this happens. Emphysema is when there is a destruction of alveoli, and instead of, I'm going to get a picture. So normally, I'm actually going to copy this image. That is from ResearchGate, should you want to go back and look at that. So normally we have these nice, I wanted you to see the alveoli anyway. Okay. Alveoli look like little grapes on a stem. So you're going to have a bronchiole here, and stemming off that bronchiole will be normal grape shaped but hollow. These are only one cell thick alveoli. And surrounding them is a network of capillaries. So you can bring air in exchange oxygen, carbon dioxide very, very easily. People with emphysema have damage and loss of those alveoli. In addition, the bronchioles like to collapse. So they get air stuck in there, so they can't get fresh air in with their respiration. Okay. Pneumothorax, once again, I make you do a little legwork. I've done a lot for you. No tension pneumothorax, signs and symptoms. Empyema is when infection spreads into that pleural space via lymphatic fluid. It can spread from the lungs, can happen with pneumonia, typical signs and symptoms of pneumonia, but it's going to be in that pleural space. So what that pleural space means is, remember I told you there were two membranes around the lungs. That is the pleural space. So here is, so I'm getting from Wikipedia. So should you want to, I don't know what I missed in there, but I want you to have a visual of the pleural space. Okay, so here is pleural space. It's basically, just think of it as a double membrane. So you could get fluid in there, which is pleural effusion in general, but it specifically can be empyema. Not sure. I wonder what most practitioners call it. There is. This is from an infection. I believe this can be just fluid. Okay, that would be my guess of the difference. But anyway, I'm not showing this as pleural effusion. Just to be clear, I put this in so you could see that double membrane. Okay. Okay. Common causes of pulmonary edema. How does the heart affect this process? Hint, right and left-sided heart issues, okay? So review those. Once again, I make you do a little bit of legwork. All right. I don't know why I can't get down here. There we go. RSV, it used to be I only ever heard of this in kids. It seems to be everywhere now. It's probably just because we're testing it, my guess is. But, and you guys could probably teach me about this. This is a virus that causes fever, cough, bronchiolitis. So that's going to be inflammation of the bronchioles, as you know. Children are at a greater risk for this, but I'm hearing more and more people have it as grown-ups. My guess is maybe we just weren't getting tested as much. I'm not quite sure. All right, my friends, that brings us to the end of our review. As always, you should also reference the book in your notes and review as much as you can. Study, study, study. I do hope this helps. You take care. Let me know if you have any questions.